He is having a case and he will be attending in another 2 minutes. Tech support, is it okay? Shall we start?
Yes, sir. I give you count. After my countdown, you can start, sir.
Yeah, please.
Yeah. So we are starting in 3, 2, 1. Please start, sir. We are live.
Thank you. This is Rajshekhar and I am from Bayer Oncology. I welcome each and everyone for this eminent session, that is updates on prostate cancer. We have here eminent speakers with us, and I welcome Dr. Harshit Garg, who is consultant urologist, and he is having specialist. He is specialized in urology, uro-oncology, and also robotic surgery, and he is from Apollo Hospital, Delhi. Sir, I give a warm welcome to you for this program, and I request you to kindly take over this program and introduce other speakers and their sessions, please.
Thank you, Rajshekhar. Thank you, first of all. Thank you, Bayer family, for having us and, allowing us to have a discussion. So, as we know that metastatic hormone-sensitive prostate cancer is always a domain which is, being a medical oncologist and surgeon and even radiation oncologist, it's a very overlapping domain. And we all are trying our best to give best to our patients. And so we have got a newer drug, not fairly very newer, but, it has been there for some time, but now its indications are expanding, and this is daralutamide, one of the fantastic drugs we had experience with. We don't have very extensive experience because of the cost limitation, but right now, as we are building up on that, it has shown tremendous results, and I think we have a fantastic panel discussion and fantastic talks for next 1 hour. I'm really pleased to have Dr. Vishrut Raj with me, who is a senior consultant of urology Uro-onco in Sagar Hospital, Bengaluru. He is a fellowship trained uro-oncologist and robotic surgeon. So welcome, Dr. Vishrut. I think Professor Ginil Kumar would be joining us soon. He needs no introduction. He's one of the key people in uro-oncology in India, and he leads the unit of uro-oncology at Amrita Institute of Medical Sciences, Kochi. And I think sir is just busy in one of our his cases, but he would join us soon. And apart from that, we have a wonderful discussion. We have audience very enthusiastic. We have wonderful audience with us who will have a remarkable discussion, I suppose, very enthusiastic discussion. We have a very interesting case with us, and a very practical case. We will a live case which he was been treatment with darolutamide for past 1.5 years with me, and we'll discuss about him as well. So without wasting much time, I would like to welcome Dr. Vishrut Raj to tell us about darolutamide. How is it actually backed, the evidence is being backed up by the real time evidence, because that is what we need to know, what is happening in real world. So Dr. Vishrut, over to you.
Thank you, sir.
You can share your screen, I think.
Yeah, I'll do that.
Yes, sir, it's opening.
Is it seen, sir? Seen? Yeah. All right.
It's buffering, sir. It's buffering, sir. I think so. Now it's clear, sir.
Clear?
We can see.
Yeah. So good evening, everyone. I'm Dr. Vishrut K. Raj, consultant urologist and uro-oncologist at Sagar Hospitals, Bangalore. Firstly, I would like to thank the Bayer company family, Mr. Rajshekhar, and of course, Dr. Harshit and Ginil sir for giving me this opportunity to not only learn a little bit about darolutamide myself, but also share what I've learned. So like Dr. Harshit said, though it's not been a new drug, it has been there available with us for some time now, but our experience has been a little limited as compared to the other ARB inhibitors available. But nonetheless, I think this is going to open a few eyes, all our three talks and the discussion that follows. At the outset, I would like to apologize if there's any network issues. I've been traveling and I'm not really 100% confident of the network, but I'll try to do my best. So the topic allotted to me is bridging clinical gaps in non-metastatic CRPC and darolutamide's role in the same, which is of course going to be backed up by real-world evidence with regards to many trials which have come out in favor of darolutamide, right? So let's start. So These are the disclosures, not very important at the moment, but what is important is the last line in red. At the moment in India, the approval status of darolutamide is for treatment of non-metastatic CRPC patients and metastatic hormone-sensitive prostate cancer patients. Generally, metastatic hormone cancer prostate patients, we always use them in combination, either as a doublet therapy or more favorably a triplet combination, right? Yeah. So, what am I going to be talking about will be an overview of what exactly non-metastatic CRPC means, how darolutamide can address this unmet need in non-metastatic CRPC patients, and a few slides about an important trial, which is the Darol trial, and a conclusion of whatever I speak about. The first part is about what exactly non metastatic CRPC or non metastatic castration resistant prostate cancer means. As we all know, once a patient presents with a diagnosis of non metastatic hormone sensitive prostate cancer, the natural progression of prostate cancer takes it through these following stages. After, if it's a localized disease, after treatment, the patient can have a biochemical recurrence, following which he can land up with non metastatic CRPC, or it can be progressed to a metastatic hormone sensitive prostate cancer and then to a non metastatic CRPC. What the worldwide data shows right now is that 10 to 20% of men diagnosed with prostate cancer will develop CRPC within 5 years of follow up. This is a very, very important piece of information, which is the reason why, the sole reason why we have so many drugs in this particular space, each trying to outdo the other, right? And which also is a very important target zone in the treatment of our patients. And almost 86% of patients with metastatic CRPC will progress from a non metastatic CRPC, marking this area as a prime zone of treatment and introduction of various drugs and various treatment modalities in this space. Patients with non-metastatic CRPC have rising PSA levels, but the problem is that most of these patients, in spite of having a rising PSA level, they will be mostly asymptomatic with regards to their cancer. And that is what makes it a challenge in, firstly, diagnosing the patient as a non-metastatic CRPC, secondly, convince them to stay regularly follow up. The other thing is convincing them to take the treatment offered, because they will not understand the seriousness of the present situation they're in. Without a androgen receptor inhibitor treatment, one third of these non-metastatic CRP cases will eventually progress to a metastatic CRPC within 2 years. So very dangerous. So that is why the importance of this particular session tonight. And the other important thing one must know is about the PSA doubling time. Obviously, patients with a shorter PSA doubling time are at a much higher risk of distant metastasis, and therefore, these are the patients where there is an urgent need for treatment. And PSA doubling time is a very strong predictor of the disease progression speed also. Generally, patients with a shorter PSA doubling time, that is less than 10 months, are at a much greater risk of developing distant mets. And we all know, just like any other cancer of the body, metastasis is always associated with a decreased survival and quality of life, as well as increased healthcare costs to whichever country or system they might be in. So, what are the key areas here? What would you want to improve with regards to your patient? One is obviously extending the overall survival, which is the most important thing. Whatever treatment we give, we wanted to extend the overall survival of the patient and delay the development of metastasis. And these are the key goals, key therapeutic goals in men who we are trying to treat with non-metastatic CRPC. At the same time, tolerability, which is very important. Just giving a tablet or a treatment or an injection is never enough. It should be tolerable for the patient to satisfactorily and comfortably take it without it impacting their daily lives. And the other one is, of course, the quality of life. No matter what treatment we recommend or give to the patient, his quality of life must not change drastically, definitely not in a negative direction. And only then they will be motivated enough to take the treatment we suggest, right? So, how does darolutamide address this particular unmet need? These three important factors I just spoke about. So, a brief about darolutamide, we all know that it's a non-steroidal androgen receptor antagonist, which has a very high binding affinity and selectivity for the androgen receptor. Right? So, by binding to the androgen receptor in a highly selective fashion, it prevents the dihydrotestosterone from binding to the same receptor and thereby keeping the progress of the cancer and metastasis from happening. And as has been proven and as has been studied extensively, darolutamide significantly prolongs the overall survival. And like me and Dr. Harshit were just discussing before we started this program, there is a superb and robust PSA response in men who we treat with the darolutamide in a non-metastatic CRPC. The PSA response is very fast and very favorable, and also while having a good safety and tolerability profile. We'll get into the nitty and gritty of that in the upcoming slides. As was seen in the Aramis trial, compared to a placebo, the overall response, PSA response, it drops to more than 50% in 84% of patients in whom we start darolutamide. Yeah. So we just spoke about the adverse events and why patients would want to discontinue any androgen receptor inhibitor that you start. So the three important trials in this space are the Aramis trial, the Spartan trial, and the Prosper trial. The Aramis used darolutamide versus placebo, the Spartan used apalutamide versus placebo, and the Prosper trial used enzalutamide versus placebo. Please note that these three trials all have different clinical scenarios and they are not directly compared to each other. They have all been compared to placebo. But nonetheless, as you can see, the rates of discontinuation of darolutamide are the least as compared to apalutamide or enzalutamide across the three trials, right? So patients were happy to continue these medicines, especially darolutamide, for a longer duration without abandoning the treatment. Coming to the adverse events, the most common adverse events that you would get reported from patients are fatigue, falls, fractures, rashes, very importantly, cognitive and memory or mental impairment, and most importantly, hypertension. So, again, these three studies have been compared, Aramis, Spartan, and Prosper. As you can see, in each of these adverse effect categories, the proportion of patients having these adverse effects are the lowest with darolutamide. Only 13% fatigue, only 5% falls, and 5% fractures, 3% rashes, hypertension of 7%, and a cognitive and mental impairment of only 2%, as compared to apalutamide in Spartan and Prosper, which were significantly higher. One important trial. This is the last two slides that I presented were what the data showed, which was collected by the clinicians. But what is more important than what we tell is what the patients actually feel and what the patients actually report, right? So the DEER study was one where it was a real world setting study where the patients reported what they were undergoing. That is far more important than what I would say or what the data says. So even here, as you can see very clearly, this DEER study utilized a large electronic medical record database of almost 800 and more patients with non-metastatic CRPC. All patients were from the United States. And even here, it is very clear that the proportion of patients who with a discontinuation or progression to metastatic CRPC was much lower with darolutamide, right? It was only 36% as compared to 51% with apalutamide and 51% equally with enzalutamide. So a very low proportion of patients discontinued the treatment or progressed to metastatic CRPC. And even the reasons for discontinuation of the treatment were also quite clearly much lesser with darolutamide, which is in green. As you can see, the adverse events, progression to metastatic CRPC or death of the patient or switching to another ARI. Even the cost factor also overall is the least with darolutamide, right? Clear data from the DEER study. And again, if you can take a look at these Kaplan-Meier curves, you can see that the time to discontinuation or progression to metastatic CRPC was much longer for the patient receiving darolutamide. What that means is, let's say we start patients on one of these three drugs, darolutamide, apalutamide, or enzalutamide on day one. And as you can see, apalutamide and enzalutamide are very closely related. That is the black curve and the blue curve, right? They are almost flowing in tandem. Whereas there is a clear separation of these two from the green curve, which is the darolutamide curve. And this separation occurs as early as 6 months. So on day one, if you start one of these three drugs, within 6 months, you will see that the overall benefit will start to appear as soon as 6 months, right? And there is no overlap with the confidence interval as well. So the median time to discontinuation or metastasis has not yet been reached with darolutamide in almost 340 patients, whereas in apalutamide and enzalutamide, the time to discontinuation was reached at around 20 months to 23 months, respectively. So clear point in favor of darolutamide again. There's another important study here, which is the Odensa patient preference study as well. And again, like I said, what the patients report is much more important than what we say. And numerically, more patients seem to prefer darolutamide over enzalutamide. Right? That is also clearly shown by the Odensa trial. Patients reported that they would feel less tired, they found it easier to concentrate, they would fall less often, they could multitask and do more things, they would have a better quality of life, and the medicine was far easier to take. All in favor of darolutamide in blue as compared to enzalutamide in green. One thing we forget with most of these patients are generally, by and large, these patients are on the elderly age group, and many of them will have multiple memory issues or memory issues and motor issues for whatever reason. It might be senile dementia, Parkinson's, so many other things. And in those patients, we as urologists very rarely evaluate for the memory composite, the learning, the memory score, and the motor skills, etc., which again are very important because those are the things which leads to complications, falls, etc. And as you can see very clearly, there is a very good benefit by using darolutamide over enzalutamide in this space, right? So darolutamide also has a lesser risk of drug and drug interactions. If you can take a look at this table in the right, you can see the marks in blue and red, which are the drug interactions. Okay, so comparing to apalutamide and enzalutamide, darolutamide very clearly has lesser drug and drug interactions. Like I already said, these patients are little elderly. They may have multiple comorbidities like diabetes, various CNS disorders, hypertriglyceridemia, and so on and so forth. And they would be on many of these medicines which are commonly used: calcium channel blockers, proton pump inhibitors, various analgesics. They are cancer patients, after all, who will need analgesics, hypnotics, antipsychotics, antibiotics, statins, anticonvulsants, etc. For all these classes of drugs, darolutamide has the least drug-on-drug interaction as compared to the other two commonly used androgen receptor inhibitors, right? So again, a point in favor of darolutamide. So for all these reasons, definitely has very good benefit on the overall survival, superb safety profile, very less adverse events, and patient comfort, patient continuation, and most importantly, delay in the progress to metastatic CRPC are all superior with darolutamide. So for that reason, not only in metastatic non-metastatic CRPC, even in patients with metastatic hormone-sensitive prostate cancer, darolutamide has been shown to be the only ARI to reduce the risk of death by greater than 30%, while also significantly delaying the time to metastatic CRPC. And the reason why this happens is because darolutamide was designed to be a structurally distinct androgen receptor inhibitor, which has a very low penetration of the blood-brain barrier, and which explains its differentiated tolerability and safety profile. As most of us know, one of the problems and contraindications for enzalutamide is that it crosses the blood-brain barrier, and especially in patients with a history of seizure disorder or any kind of CNS issues, it becomes very difficult to use enzalutamide, and it's not advised to use enzalutamide in those patients. And patients with hypertension or uncontrolled diabetes, which is a large chunk of these patients, using abiraterone also becomes a problem. So in those kind of cases, considering darolutamide will be very much beneficial both for you as well as for your patient. And like I already said, it consistently demonstrates a favorable tolerability as confirmed in clinical trial across more than 3,000 patients, right? So for these reasons, darolutamide is advancing prostate cancer treatment with a robust survival benefit and a tolerability benefit as well. So one study which I wanted to highlight is a present ongoing study called the DAROL study. This is quite interesting. Just a few slides about this particular one. So the DAROL study was designed to support the ARAMIS trial by assessing the safety and effectiveness of darolutamide in patients with non-metastatic CRPC in real-world scenarios, right? And the results from the DAROL study are the interim analysis of the DAROL study have come out recently. So the DAROL study is currently ongoing. It uses 600 mg of darolutamide orally twice daily. And if you take a look at this column in green, or that is the interim analysis 4. So they have around 800 patients who are on darolutamide, and the treatment duration in them has crossed 12 months already. And they hope to continue the same 800 patients for about 36 months. And at present, this data is the 12 months data which has made an initial presentation, right? So the primary outcome, obviously, is safety, and the secondary outcomes are the effectiveness with regards to overall survival, metastasis-free survival, time to metastatic CRPC, PSA response, and time to undetectable PSA, and a quality of life scoring system. So I already said the primary endpoint is safety, and the secondary endpoints are all the others. And all the comparisons between the DARIL and ARAMIS are descriptive in nature. Almost 800 patients who have completed 12 months of data and 12 months of treatment, and the data from 12 months. And the conclusions from the DAROL trial at the interim analysis stage, they indicate low incidences of treatment emergent adverse events with no new safety signals. The secondary outcomes, including overall survival, metastasis-free survival, PSA outcomes, they all support the effectiveness of darolutamide even in real-world scenarios, not just a trial setting, and with the quality of life, which is a health-related quality of life, which is relatively stable or in fact getting better in many patients. So this interim analysis represents a varied and clinically diverse population of patients with NMCRPC in real-world conditions and supports the established efficacy and safety profiles which have already been demonstrated in RMS trial, which we already saw earlier in the preceding slides. So like I mentioned, the DAROL trial is ongoing, and the last patient visit is anticipated to be in July 2026, in a couple of months in this year. And with the final answers hopefully getting reported in GU ASCO, hopefully in 2027, we should have the full picture. But the present results definitely are promising. They're reassuring that darolutamide is well tolerated and superbly effective in a broad spectrum of patients with non-metastatic CRPC. So just to conclude, a few lines on what I already spoke about, all the lines. So darolutamide is now a standard of care across NMCRPC and metastatic hormone-sensitive prostate cancer, purely because it has a fantastic efficacy profile as well as a tolerability and safety profile, which has been proved and confirmed in more than 3,000 patients across multiple clinical trials and real-world data. Patients with non-metastatic CRPC and a short PSA doubling time, less than 10 months ideally, have a greater risk of distant metastasis, and therefore they have a very urgent and imminent need for treatment. Since these patients are largely asymptomatic from their cancer, it is very important to avoid the potentially negative impacts of long-term treatment on their daily lives. This is where the importance of darolutamide comes in. And according to RMS trial, it reduced the risk of death by more than 30%, while significantly delaying the time to mets with a IP value. And the darolutamide was designed to have a unique structure, which is why it works beautifully, and it does not penetrate the blood-brain barrier, making it much safer than a comparator drug like enzalutamide. And darolutamide's differentiated efficacy and tolerability are further reinforced by this trial we just saw, the DEAR study, which demonstrates that patients in the real-world setting receiving darolutamide experience a much longer treatment duration. They successfully and comfortably tolerate it with the least possible and tolerable side effect profile as well. And to close, with darolutamide, patients can extend their survival without affecting activities and quality of their daily living. That concludes my talk. Thank you. Thank you once again for the opportunity. to Bayer as well as Dr. Harsh and my mentor, Dr. Ginil as well. Thanks to everyone. I hope my talk was heard properly and the slides were seen properly. I was not sure of the network.
Yes, sir. Yes, sir. It is quite clear, and it was very.
Okay, okay. Thank you. Like I said, I'm traveling, so I will log out now. I will be happy to answer any questions. I'm sure Dr. Harshit and Dr. Ginil have more experience than me and will be able to answer better than me. But if any particular thing is there, I would be happy to answer them at a later time. Is that okay,
Yes,
Rajshekar?
absolutely understandable, sir.
Sure.
Thank you, sir.
Okay. Thank you. Thank
Nice
you.
to hear
Thank
from
you.
you. It was an excellent talk.
Yeah. Sir, thank you. Ginil, sir. Good evening, sir. How are you, sir?
Good evening. Yeah, doing well.
Thank you, sir.
How are you, sir?
You're traveling, isn't it? Yeah, hi, Harshit.
Hi, sir. I think you're finishing a case.
Not finished. Two cases are going on.
Oh,
for the
wow.
sidelines. Yeah.
Nice. I think, thank you. I think it's my time to, invite you to the podium. So I'll just do the honors. So Dr. Ginil needs no
Thank
introduction.
you.
Thank you, Dr. Vishnu. And Dr. Ginil needs no introduction. He's one of the key figures of uro-oncology in India. And I think he's gonna tell us about the latest with the trials. That is the all which we are following. I think a lot of discussion happening on that trial particularly, which is the Aranote. So Dr. Ginil, over to you.
Yeah, I shall share my. Is it visible there? One
No,
second.
sir.
One second. No, one second.
Satish, bata.
Sir, now it is visible, sir.
Yeah. I was lucky to be a part of two of the trials. One, the Aramis in the Indian arm, and Arnott. So I can personally tell that this is actually a wonderful drug. I'm very much impressed about the side effect profile because it was well tolerated. Only thing I don't like is the cost at which it is coming to India. If it is coming down, it would have been very helpful for a lot of patients. So my slide is visible, isn't it? So my talk is on advancing metastatic HSPC treatment horizons with darolutamide without chemotherapy or not. So as you know, there are at three levels the darolutamide is tried. One is at non-metastatic, which Sudha has already discussed. Then in the metastatic scenario, without chemotherapy and with chemotherapy. These are the three areas where three lines in which darolutamide is used. So this is the disclosure. So in the last decade, there was a huge change in the management of metastatic CA prostate. In the stage before it became castration resistant, we used to give a single hormone treatment earlier. That has changed in the last decade because of this different trials, which shows that if you are adding different molecules, the effect is better. So initially, it was charted with docetaxel, which showed benefit in high volume disease. Then came the Stampede. Again, it showed that in the high volume disease, docetaxel is effective. But the game changer were the Latitude trial and abiraterone arm of the Stampede, where it was shown that combining an abiraterone can delay the progression and delay the and it was if you're comparing, even it was less toxic and had a slightly better effect than the docetaxel across, like in low volume and the high volume disease. This followed followed different trials using enzalutamide, apalutamide, and then the darolutamide. So darolutamide trial was started before the Latitude trial result came. So otherwise, the standard of care would have been changed. So the Aeronaut trial uses darolutamide with ADT. The recent trial, that is Arasens, combined with the docetaxel and found that it is very useful, especially in high volume disease. It was actually we had one more trial in this with the same combination abiraterone and docetaxel, which also showed a benefit in high volume disease. But majority of us, if patient can afford, prefers darolutamide because the side effect profile it has got. So we have got some unmet needs in metastatic HSPC, and those needs are taken care in these trials, Arasens and Aeronaut, by combination of docetaxel with darolutamide and ADT, as in Arasens, or Aeronaut, where the trial was without chemotherapy with ADT and darolutamide alone. So in the Arasens, we have docetaxel, darolutamide, and ADT, and it has shown huge benefit in metastatic HSPC. So it was especially specifically beneficial in high volume disease, and even in low volume disease, there was some benefit. Aeronaut trial is basically without docetaxel, and this is the trial flow chart. It was against placebo and 2:1 randomization. So the different factors like visceral metastasis, present or absent, prior local therapy was given, these things were assessed. It was an open label with crossover to a darolutamide. It was 2:1 randomization. So you can see that the important things about this trial is the distribution of patients across the globe. There are a good number of Asian population, Black population, and white population, and across the globe, different races and different ethnic population were involved in the trial. That is the beauty of this trial. And it was against placebo and ADT. You can see the distribution is, compared to other trials, the distribution is across the globe. It was not concentrated in any part of the globe. You can see that good number of patients were recruited from China, India, Taiwan, and almost all the region. So in analyzing the result, it reduced the risk of radiological progression or death by 46% versus placebo. So you can see that the graph Kaplan-Meier is widely deviating apart, and at 24 months at the placebo it is 52%, and in the darolutamide 70% plus. So this is significant. You can see the hazard ratio coming to 0.54, well below 1, and p-value very low. So in the forest plot, you can see everything is the PSA value, all the factors actually were favoring for darolutamide across the subgroups. Benefit was favoring the darolutamide.
So on visceral mets, any comments on visceral mets per se?
Visceral met, yeah, you can see that visceral mets, it was 21 and 13. I think this was actually crossing 1, but the main bulk of the patient was less than 1. So when it's crossing 1, probably we cannot, this is the range is between 1.35 to 1.41. So there may be a benefit, but maybe we have to reassess the data because it is crossing 1. That is one thing I could understand from the chart.
Yes, sir.
So most important thing is high volume, low volume, both factors, there were a difference. And in the low volume, you can see the HR is very, very low, 0.3. And in high volume also, you can see that it is better than the chartered with 0.6. So in different secondary endpoints like time to metastatic CRPC, time to PSA progression, different factors were analyzed, and time to PSA progression was significantly deviating to below the 1 mark. So in almost all the factors, darolutamide shows benefit. So overall survival, there can be a trend, but again, as discussed, it was crossing 1.1. We cannot, but thing is, there is a trend towards overall survival benefit. All the other factors, metastatic CRPC, there is a benefit, there is a huge benefit, and probably if you are following this patient for longer duration, this benefit of metastatic CRPC would have reflected in the overall survival also probably. At the time of primary analysis, the overall survival data was immature. You can see from this data. You can see the time for metastatic CRPC, time for pain progression. Everything was beneficial. And PSA response, who reached less than 0.2, it was significantly higher compared to like 62.6% versus 18.5%, was significantly better if darolutamide is added. So the graph itself tells how different it is. So you can see that a higher percent of patients had undetectable PSA in darolutamide in both high volume and in the low volume disease. So when we discuss about chance of progression and having a subsequent treatment, the subsequent chemotherapy, anti-neoplastic therapy, was significantly reduced if darolutamide is added to ADT. Most important thing about darolutamide is the adverse events. The adverse events were significantly less compared to even it should have been now. This graph we cannot explain is even better than the placebo, but what we see is actually by adding darolutamide, the side effects are not significantly increased compared to the ADT. in our trial where we were a part of the study also, it was well tolerated. So fatigue, you can see that is almost 5.6 and 8.1, possibly because of the response to the with the disease, patient is having a better side effect profile in darolutamide. So that may be one thing by which we can explain the benefit in the even the side effects compared to placebo. We can see the darolutamide wins over placebo in a lot of areas. So the different adverse events is very rare. These adverse events are discussed. Is you can main discussion will be like cardiac events. So cardiac events is not increased by adding darolutamide. You can see the cardiac arrhythmias, coronary artery disorders. You can see that 3.6% and 1.4% we have to check whether it's significant. But cardiac ischemia is there is no difference. So most important thing is the quality of life. Probably is giving huge benefit by the response to the disease. The side effect is the quality of life is very much improved in darolutamide. And also side effect profile is very favorable. So basically in the pain progression and overall well-being, the darolutamide was there was clinically meaningful benefit. So all these factors regarding the quality of life can see that the forest plot is towards darolutamide, favoring darolutamide in the social well-being, functional well-being, and even in urinary symptoms because of the response. There was significant shift towards darolutamide. So to conclude, darolutamide plus ADT significantly improves progression-free survival in patients with metastatic HSPC. Darolutamide showed benefit across all secondary endpoints. Darolutamide was associated with a deep PSA response regardless of baseline PSA. This is the first and only AR inhibitor to demonstrate clinically meaningful delays in pain progression, overall well-being, including social, family well-being, functional well-being, urinary symptom, and it has a better favorable safety profile. So darolutamide and ADT, if you are going for a next generation hormone suppression, darolutamide probably is beneficial, except for the if the patient can afford, darolutamide may be a better option. Thank you very much.
Thank you, sir. I think it was a fantastic presentation, and I think we all have witnessed how darolutamide is changing the world, and the only cost is the constraint. And I think I always say there's a one drug in prostate cancer which has actually got great results in terms of, I I think I recently had a patient last week. His PSA was 387. It was a high volume, non-visceral metastatic CA prostate, lesion 4+4. And just three, and he also had a kidney cancer, so I had a robotic partial for him. It was a clear cell RCC. And just before that, during PAC testing, he got his PSA done 3 weeks after Darrow, and it was 2.2 after 387 in 3 weeks. And I could not, I was not able to imagine, how fast or swiftly this drug is working to bring down the PSA.
So in our population, actually, if you are suggesting a triplet, we always suggest darolutamide as the first line compared to others, because if with the side effect of chemotherapy, we don't want one more side effect to happen of steroid or fatigue of enzalutamide. So in those patients, we specifically tells the patient that there's a huge benefit. And the doublet, a lot of patients, the poor patients, what we are seeing, some they may not be able to afford, but for patients who has got support from financial, when there is a support, like whether they can, if they can afford, or like different schemes, they can have the support, then probably darolutamide has to be preferred because the side effect profile is better.
Yeah, absolutely, sir. I think I have a case presentations. I'll not waste much time, and I'll share my slides. So, can you all see my case there?
Yeah, yeah.
Slide. And I think I will, Dr. Vishruth is here, or has he?
I think we should told that he's traveling.
Okay, okay. So I think we just have a small case and we can just have a quick discussion on
Yeah,
that.
sure.
And check it. Wait, wait. So I think so this patient, he was a 64-year-old male and he had this mild hypertension, is a good performance status, and he actually presented tingling numbness of left hand. He was a doctor, he was a community medicine doctor, and who was some at high post in Central Government of Health Services. And so he got his routine testing done while he was being, CBC KFT, got a routine package, and he was found to have a PSA of 149. And then he underwent a standard MRI, which was Pyrite 5 lesion for prostate. He underwent a biopsy, which is Gleason 4+5, adenocarcinoma, PNI present. And so I just show the MRI cervical spine, which was, done for him, which showed, a lytic lesion in C7 and encroaching neural foramina with compression of C7 nerve root, classically, which was affecting his thumb. And he, of course, had multiple level of, thecal indentations at various cervical levels. And he underwent a PSMA PET, and it was, diffuse gland uptake, SV uptake, and, very high super scan, which you call bone scan, like that. Skull, clivus, multiple ribs, thorax, disease almost in every bone, multiple lymph nodes. And just so he just finished his 1.5 year with us, and I just got a call from nuclear medicine 30 minutes ago, a coincidence, that we I've never seen such a great response. We are comparing his PET scan serially. There are no lymph nodes at all. The bones, there is no avidity. So, and it was super scan early. He just gave me a call that I'll give the report tomorrow. So, but he was himself amazed that what I'm giving him. So, so he was basically a metastatic CA prostate with spinal involvement with skeletal nodal mets. So it was a high volume, non-visceral metastatic HSPC. And he, of course, landed up with the radiation to spine because he was having those symptoms of compression there. And he was initially started on Degarelix. And my general, because of cost and everything, I start with enzalutamide, 160 mg. He was hypertensive. I'm not a great fan of Abby per se. But when I started with enzalutamide, so he developed facial edema and he was not very happy. So I said, okay, we have much, one more better analog, and that was apalutamide. Then I started, but he said, edema is still there, and he's put some rash, and he was not very, happy. So I gave him option. We have got darolutamide, and that Aranote was there, and so he started on darolutamide, and once he started on Dynamo, he was super happy. He's now 1.5 year down the line. And 3 months post-op, we did a PSA of 0.2 from it was started 149, and serum testosterone, of course, in castration range. And he's continuing on the therapy. And the last follow-up we have from May, and he just got a PET scan yesterday. And so his PSA is 0.17 and serum testosterone is 12 on that day. And so he's right now on Daro and Relugolix for androgen deprivation. So I think very straightforward case, sir. So what are your thoughts on this?
Yeah, if you are going for triplet, we have got different options, the Peace One and Arasen's two trials supporting that. So, as you told, beauty of darolutamide is the side effect profile. I really appreciate because I've used it in the trial, and almost all the patients tolerate it well. Only concern for me is if to give whether they can afford. Otherwise,
Yeah. And so this patient,
this is a so this patient will be having it is I think it is available through ECHS and other
TGHS,
schemes.
yeah. So
So
schemes,
TGHS,
they have to pass through a committee, I think.
yeah.
To get the committee
So
approval, special
patients
committee
like
approval.
this, probably if they have a choice, is always better to have a darolutamide. And if company is coming with some schemes, probably more and more patients will be taking uh, darolutamide. Yeah.
Yeah.
This
And
patient, just for curiosity, there was any impending fracture for which a fixation is required, or just it
so
was
just a
not coming?
compression, mild compression,
A mild
and just
compression,
that
it
two weeks
responded
sensation,
to RT,
radiation,
luckily.
and
Otherwise, if he is progressing, would have been in paraplegia. So there also, when such a thing is there, a quick response is required. So as what you have done, a Digerlix or a antagonist plus darolutamide and the chemotherapy together will give a quick response, and that is the maybe it may be better than a simple orchectomy. So we have to be very aggressive in this patient, because and long term also the response will be better if you are combining all these trimodality.
yeah. I think he was not very pro chemo. I gave him because of high volume superscan disease. I gave him a upfront option, but and then he came with a question which actually Neeraj also asked one of our conferences, that there is no data comparing triplet with the doublet upfront, like ADT plus they have used placebo or ADT alone plus ADT plus dosi plus one of the RPs or RCs versus ADT plus RP/RC. So that data is little bit not an upfront data. We have got some collaborated on that. We
Yeah.
take out extract data and
So,
extrapolate it.
yeah, one thing I used to discuss in Aeronaut also, they should have compared with existing one medicine and should shown the superiority that abiraterone. Definitely it would have been a successful trial if they had done, and could have made a more impressive entry into the market, because they have compared with the placebo. If they have compared with the abiraterone or
Enza.
enzalutamide, would have been even better. So, probably, yeah, no, the placebo controlled is one weakness we have, even though the response was, uh,
Great. Yeah.
yeah.
Just a quick thought, just a quick, question from you. Do you think that now we are, these are very good, androgen receptor signal inhibitors, Enza, APA, DARO. So do you think that there would be a time where we would actually get away from the, conventional ADT, like TAB is no longer used, bicalutamide. So maybe, or we can just actually use intermittent ADT more, more happily, or do you think that still, the world of, all these anti-agonists and relugolics would go on with them?
Actually, in the Embark, uh, there was an arm where enzalutamide alone was used, then enzalut plus ADT, and so best response was with ADT plus enzalutamide, then enzalutamide alone, then ADT alone. So maybe it may be better than ADT alone, but a combination may be superior. That is what the Embark trial tells.
Yeah, and I think maybe with Darrow, because Darrow is such a, more stronger agent, I don't
Yeah.
know with Darrow, how would Embark behave?
So yeah, we should have a trial with darolutamide, uh, uh, like a Embark trial. It would have been so a lot of areas where we can proceed. Like they can compare with the existing molecules like
Yeah,
enzalutamide and other medicine. They
we
can
need
be
a
a trial.
stampede.
Yeah,
We need
comparing
another
that.
stampede for them.
Yeah, then we can duplicate the Embark trial with the darolutamide. There are a lot of opportunities for darolutamide which need to be explored.
I think anyone else from the house who has any questions to be discussed or want anything? I think Dr. Mr. Rashekar, I think over to you. I think we had a really enthusiastic discussion on darolutamide, its evolving role, and
Sir, absolutely, sir. It was a very insightful and great discussion which we had. To be frank with you, sir, as a Bayer, we strongly believe in sharing science and sharing knowledge. And with your as well as Dr. Ginil and Dr. Vishruth support, we had an opportunity to have a wonderful session today. And in fact, I sincerely thank all the eminent speakers as well as audience for attending this session and making this more fruitful. And I think so. Thank you so much, sir.
Thank you, Rajshekar.
Thank you,
Thank
sir.
you,
Thank you, sir.
Rajshekar.
thank you so much.
Bye-bye.
Bye, sir.
Bye.
Thank you, audience, for joining. Tech support, you can, I think so. You can disconnect. I mean, you
Yes,
can
sir.
close the session.
Yes, sir. Thank you.
Thank you.